So, shall we start, Banu?
Yes, sir.
So, good evening, one and all. Welcome to ISA Telangana webinars. This is second webinar in this year. Hopefully, we'll continue. So, today's topic is inotropes and vasopressors in anesthesia practice. Speaker is Dr. S. Prashant Reddy. He's head of the department, anesthesia, pain, SICU, Yashoda Hospital, Somajaguda. So, now I request Dr. Banu Lakshmi to take over and continue the program.
Yes, thank you, sir.
Thank you.
Good evening, one and all. Welcome to another session of PG teaching program, where we are discussing on topics useful to the PGs. Hope they utilize this opportunity to enrich their knowledge. So today we have here Dr. Prashant Reddy, who is talking on vasopressors and inotropes in anesthesia practice. To introduce him, presently he is working as HOD in Yashoda Hospital, Hyderabad. Previously, he held various positions, HOD anesthesia and liver transplant in National Institute of Gastroenterology and Liver Diseases, Hyderabad. He worked as a HOD anesthesia at Century Hospital, Hyderabad. Senior consultant liver transplant anesthesia at AIG Hospital. Then senior consultant cardiac anesthesia at Care Hospital, Hyderabad. He also worked as a senior consultant and core group member in Prerna anesthesia and critical care team. His field of interest is transplantation anesthesia, cardiac anesthesia, and operation theatre management. Welcome to the webinar, Dr. Prashant. Over to you.
Thank you, Banu, and thank you, Ramkrishna sir, and thank you everybody for giving me this opportunity. So, not wasting much time, I'll be discussing about inotropes and vasopressors in anesthesia practice. These drugs we will be using in severe hypertension, which are impending to go into shock. The problem with this is the hallmark of shock is there is no tissue perfusion and oxygen delivery is hampered when there is shock. So decreased cardiac output or decreased systemic vascular resistance, any of these can lead to decreased mean arterial pressure and systemic tissue perfusion, decrease in tissue perfusion, which will further lead to multi-organ dysfunction. These are all can be avoided by using various goal-directed therapies before the multi-organ dysfunction comes in. So inotropes and vasopressors are the key in the management of shock. So these inotropes, as you all know, these are the agents which increase the contractility of the cardiac myocardium, and then vasopressors are the drugs which increase the systemic vascular resistance, that is cause vasoconstriction of both arteries and veins. So if you see this equation, cardiac output into systemic vascular resistance is equal to mean arterial pressure. That tells you the importance of maintaining cardiac output and systemic vascular resistance in maintaining the mean arterial pressure, further maintaining the tissue perfusion and oxygen delivery. There are various types of agents. Most important of them are the catecholamines. Catecholamines, they are both endogenous and synthetic, and non-catecholamine sympathomimetics. These are the agents which we commonly use in the operation theatre in day in and day out. And other important agents are vasopressin, phosphodiesterase 3 inhibitors, and calcium channel sensitizers. We'll be discussing all these agents today. So before going to the agents in particular, we need to know certain physiology pertaining to the sympathetic nervous system, because sympathetic nervous system is the system which plays the key role in maintaining the hemodynamics. So before going into the actuals, we need to know certain receptors in the synaptic cleft of sympathetic nervous system. So the most important would be the alpha 1, beta 1, beta 2, and the dopaminergic receptors. Alpha 2 receptors, which are the presynaptic receptors, they do not play these sympathomimetics do not have much action on the alpha 2 receptors. So the agents mainly have the agents which we are going to discuss today. They mainly have the effect on alpha 1, beta 1, and beta 2 receptors. So alpha 1, usually most of the times they are only post synaptic receptors. Beta 1 are also mostly post synaptic receptors, whereas beta 2 receptors, they can be either presynaptic or postsynaptic. And presynaptic beta 2 receptors and postsynaptic beta 2 receptors, they have actually quite opposite mode of action. Whereas the dopaminergic DA1 receptors are mostly postsynaptic receptors. DA2 receptors, that is dopaminergic 2 receptors, they can be presynaptic or postsynaptic. So the beta 2 receptors, when they are presynaptic, they actually increase the uptake of norepinephrine and provide more norepinephrine to the synaptic cleft. Whereas when they are on the postsynaptic side, they act more or less like opposite action to the beta 1. That is, they cause vasodilatation, whereas alpha 1 causes vasoconstriction. So there is that is the opposing effect of beta 2 receptors. Then these are all the receptors which we have discussed. So coming one by one, alpha 1, as I said, they are usually postsynaptic receptors. The important thing to be remembered is they are mostly found on the vascular smooth muscles, and the action would be whenever alpha 1 receptors are stimulated, they lead to constriction of the vessels. That is the thing to be remembered. Then beta 1 receptors, these are also postsynaptic receptors. These are mostly present in the myocardium and the synatrial node and ventricular conduction system. So whenever beta 1 receptors are stimulated, it leads to positive inotropism and chronotropism. Then beta 2 receptors, they are, as I said, they are both presynaptic and postsynaptic. Presynaptic, they are present in both are present in myocardium and vascular smooth muscle, whereas postsynaptic are mostly present in vascular smooth muscle. Then beta 2, actually beta 1 is predominant in myocardium. Beta 2 is present to a certain extent, but it becomes important in a chronic heart failure patient with decompensation, wherein all the beta 2 or beta 1 are downregulated. So beta 2 takes over and maintains the contractility of the heart. Whereas the postsynaptic receptors, they are mostly found in the vascular smooth muscle, leading to relaxation. So alpha 1 and beta 2 have got opposite actions. Alpha 1 has got constricting activity on the vasculature, whereas beta 2 has got relaxation activity on the vasculature. The dopamine 1 and dopamine 2 receptors, these are acted upon only by one agent, that is dopamine. So DA1 receptors are usually present on the blood vessels. This leads to stimulation of DA1 receptors leads to vasodilatation. It is also present on renal tubules, which leads to increase in natriuresis and diuresis. Then DA2 receptors are also found on vasculature. This also leads to vasodilatation. Apart from that, dopamine also has effects on alpha and beta receptors, which leads to the action of inotropism and chronotropism and vasoconstriction. So what happens when a beta receptor is stimulated by these agents? So whenever a beta receptor is stimulated, there is increase in the cyclic AMP levels in the cell. If you see this side, this is what happens in a myocyte. That is, there is increased calcium channel activation, leading to actin, myosin, and troponin interaction, leading to positive inotropy and positive chronotropy. So this is more or less the action of beta 1 receptors. That is, the calcium is increased in the cytosolic calcium is increased, leading to actin, myosin, and troponin interaction. Whereas if you take this side, this happens in a vascular smooth muscle. That is, here also cyclic AMP is increased, but the action of cyclic AMP is to actually decrease the cytosolic calcium. The calcium is taken up by the sarcoplasmic reticulum, taken back into the sarcoplasmic reticulum, and leads to vasodilatation. Whereas whenever a alpha receptor is stimulated, alpha 1 mainly is stimulated, it leads to increase in the cytosolic calcium, leading to vasoconstriction. So these are different types of sympathomimetic agents, catecholamines. This is how they are produced in the synthesis of the endogenous catecholamines happens from phenylalanine, which is converted to tyrosine by phenylalanine hydroxylase. Then tyrosine is converted to L-dopa by tyrosine hydroxylase. L-dopa is converted to dopamine by dopamine decarboxylase. Then this is the first catecholamine which has action on beta and alpha receptors, which is sympathomimetic. All the above agents, they are all amino acids. They don't have any action on any sympathomimetic action. So dopamine is the first sympathomimetic action. It is the precursor of norepinephrine and epinephrine. They are all formed from dopamine. So then these three are the natural or endogenous catecholamines: dopamine, norepinephrine, and epinephrine. Whereas dobutamine, isoproterenol or isoprenylene, and phenylephrine, these are all synthetic catecholamines. Phenylephrine actually cannot be called catecholamine because any catecholamine should have a benzene ring with 2 hydroxyl groups. If you see all this, there is a benzene ring with 2 hydroxyl groups, whereas phenylalanine does not have a second hydroxyl group. It has got only 1 hydroxyl group. So it is a non-catecholamine sympathomimetic agent. Phenylephrine and ephedrine, which we commonly use in operation theaters, they are non-catecholamine sympathomimetics. If you see dobutamine and isoprenylene, they also have 2 hydroxyl groups, which makes them catecholamines. Coming to individual agents, dopamine, as I told you, it is a endogenous catecholamine agent, and it is a precursor of norepinephrine and epinephrine. It has got action on different receptors. Apart from the beta and alpha receptors, it also has action on dopamine receptors, DA1 and DA2 receptors. This action happens at lower doses, that is at doses of 0.5 to 3 microgram per kg per minute. They act on the dopamine, it acts on the dopamine receptors, leading to vasodilatation, especially the splanchnic and renal vasodilatation. So this vasodilatation leads to increased renal flow and increased urine output. So this was the concept of low dose dopamine, or renal protective dose of dopamine. But nowadays that concept is challenged, and nowadays we don't use low dose dopamine for increasing the urine output as a renal protection agent. At moderate doses of 3 to 10 micrograms per kg per minute, it acts on beta 1 and beta 2 receptors, leading to chronotropy and inotropy. And at higher doses, more than 10 micrograms per kg per minute, it acts on the alpha 1 receptors, leading to vasoconstriction. Dopamine, apart from acting directly on the receptors, it also leads to increase in the it also induces the release of norepinephrine, and so that way it has got both direct and indirect actions as sympathomimetic. Dobutamine is a synthetic catecholamine. It has got strong beta 1 and beta 2 agonist action. So the ratio of beta 1 to beta 2 agonism is about 3:1 ratio. That is, it has got a more beta 1 propensity compared to beta 2. But still, there is some amount of beta 2 agonism leading to vasodilatation. So it can be called a vasodilator. Remember, whenever there is severe vasodilatation, dobutamine is not the agent of choice. Dobutamine is agent of choice only when there is cardiac pump failure or when there is decreased ventricular function. So whenever you are using dobutamine, you have to be careful that it can lead in a normal cardiac pump function. It can lead to actually hypotension rather than increasing the blood pressure. Norepinephrine is the major endogenous catecholamine. It is the most prominent agent present in all the synaptic clefts of sympathetic system. It has got potent alpha-1 action, and at higher doses, it has got some amount of beta agonism also. So all the last 2-3 surviving sepsis guidelines have picked up norepinephrine as the agent of choice in treating septic shock. And any distributive shock, norepinephrine is the agent of choice. So when compared to epinephrine, that is adrenaline, norepinephrine, the tachycardia with norepinephrine is moderate when compared to epinephrine, and the myocardial damage which happens with adrenaline is comparatively less with norepinephrine. And previously, people were using dopamine in septic shock. It was the most frequently used agent, but norepinephrine has replaced dopamine also. So the advantage with this is the tachycardia and the cardiac toxicity which is there with dopamine is comparatively much less than with norepinephrine. So it has become the agent of choice for all the vasoplegic conditions. Epinephrine, it has got high affinity for beta 1, beta 2, and alpha 1 receptors. It has got chronotropic, inotropic, and vasopressor activity. It is the beta adrenergic activities are comparatively much pronounced at lower doses. When the dose is less than 0.02 micrograms per kg per minute, beta 1 and beta 2 action, that is, it acts as a inodilator, behaves as dobutamine at lower doses. When the dose goes above that, or 0.02 micrograms per kg per minute, or more than that, then the alpha action also starts to come in. So it becomes a vasoconstrictor. High and prolonged doses of epinephrine have shown to cause toxicity. So nowadays, epinephrine is not the first drug of choice whenever there is hypotension. Previously, we used to start epinephrine first and then start other things. But then dopamine or epinephrine and then other things. But epinephrine has taken a backseat now. Epinephrine is only used whenever there is you don't see any response to norepinephrine or vasopressin, then only or dobutamine for that matter, then only epinephrine is used because it has got cardiotoxicity. It has shown to cause myocardial necrosis with higher doses and prolonged usage. And apart from that, epinephrine is preferred agent during cardiopulmonary resuscitation. 1 mg doses are given at every 3 to 5 minutes during cardiopulmonary resuscitation. And the other advantage is it can be used. It is the agent of choice in anaphylactic shock because it has got good potent beta 2 action, which leads to good bronchodilation and decrease in laryngeal edema and maintaining the pressures. So it is a preferred agent whenever there is anaphylactic shock. Isoprenoline is a potent non-selective sympathetic beta adrenergic agent. So this is got specifically action only on beta 1 and beta 2 receptors. It does not have any action on alpha receptors. So it can be only used as an inotropic and chronotropic agent, and it is much potent compared to epinephrine. It is almost more than 100 times potent than adrenaline, that is epinephrine. So it is at very low doses, it causes significant inotropy and chronotropy, and slight increase in doses can lead to malignant ventricular arrhythmias. So it is not very commonly used. It is only used in certain specific situations, like when the patient is not responsive to epinephrine, or when there is a bridge you require time to place a placement of pacemaker. In only such specific situations, isoprene is used. Otherwise, nowadays it is not routinely used in routine clinical practice. Phenylephrine, it is potent, it is synthetic alpha adrenergic agent. It has got more action on alpha 1 rather than alpha 2. So it is a potent vasoconstrictor. There is almost no effect on beta receptors. It is routinely used in our intraoperative setup to deal with hypotension of anesthetic agents like propofol, or whenever there is post-spinal anesthesia hypotension. All these are managed with small boluses of phenylephrine. Apart from that, the specific indications would be any patient who has got fixed cardiac output, like a patient with aortic stenosis, wherein the output is fixed because of the stenotic aortic valve. In such situations, to maintain the mean arterial pressure, phenylephrine is used because it has got only alpha 1 agent, and it does not cause any tachycardia, which are not preferred in aortic stenosis patient. In aortic stenosis, we don't tachycardia can be detrimental, so we don't need that. So only phenylephrine can be used to increase the mean arterial pressures and maintain diastolic blood pressure and maintain the coronary blood flow. In situations like HOCM, wherein you don't require chronotropy and inotropy, and in such situations also in hypertrophic obstructive cardiomyopathy. So in such situations wherein you have to maintain mean arterial pressure, phenylephrine is the agent of choice. Ephedrine, this is another common agent which we use in our daily practice to deal with our routine hypotension which occurs with induction agents or spinal anesthetics. It is directly and indirectly acting adrenal agonist. That is, it has got direct action and on beta and alpha receptors. It also indirectly stimulates the secretion of norepinephrine, thereby causing increase in vasoconstriction and increase in mean arterial pressures. So it is commonly used as bolus agent, as I said, but tachyphylaxis is seen with subsequent doses. So once you give one or two doses of ephedrine to maintain blood pressure, in later stages tachyphylaxis is seen because the secretion of norepinephrine is decreases with ephedrine. So only direct action is there. So the action is not so significant to maintain the mean arterial pressures. In such situations, we might have to use other agents like phenylephrine. Previously, it was preferred agent in parturients who have post-spinal hypotension. But then studies have shown that the uterine artery blood flow, the umbilical cord blood, the pH was lower with ephedrine when compared to phenylephrine. That is, there was acidosis. The fetal acidosis was also more compared to phenylephrine. So now in cesarean sections, to maintain pressures after spinal anesthesia, phenylephrine is the preferred agent compared to ephedrine. The other class of agents is phosphodiesterase inhibitors. To be specific, phosphodiesterase PDE3 inhibitors. So inside the cell, the cyclic AMP is converted to AMP metabolized by phosphodiesterase 3 enzyme. These phosphodiesterase 3 inhibitors inhibit the PDE3 enzyme, leading to increase in the availability of CAMP inside the cell, thereby leading to increased chronotropy and inotropy in the myocyte. CAMP, whenever it is increased, leads to increased chronotropy and inotropy in the myocyte. When it comes to vascular smooth muscle, increase in CAMP leads to vasodilatation. So they are typical inodilators. They increase inotropy and they cause vasodilatation. So they are potent inotropic agents. They are potent lucitropic agents. That is, the diastolic relaxation is also very good with these agents. But only problem is the vasodilatation which they cause. So it can lead to significant hypotension. That has to be taken care of whenever these agents are being used. So whenever you are using milrinone, it is always better to add some amount of norepinephrine as an adjuvant to maintain the alpha agonism. Otherwise, it can lead to significant hypertension. So these agents are so whenever there is a chronic heart failure case, or whenever there is pump failure, cardiac pump failure, dobutamine is the first agent of choice. If dobutamine is not there, milrinone is the second agent. And specifically, milrinone is useful whenever there is, with chronic heart failure, what happens is there is something called downregulation of the beta receptors. So these beta receptors do not respond to the sympathomimetic agents which we regularly use like dobutamine or epinephrine. So in these cases, milrinone is a better agent of choice. And in patients who are on chronic beta blockers, there is downregulation of the beta receptors. So in these patients also, milrinone is a preferred agent to maintain the contractility. The problem with milrinone, all the other agents which we have discussed till now, their half-life is only a couple of minutes. But the half-life of milrinone is about 2 to 4 hours. So whenever you are using milrinone, this half-life has to be taken care of. The other agent which was there prior to milrinone, amrinone, it was used for some time, but the problem with that was there was significant thrombocytopenia when amrinone was used. So amrinone is no longer available now. The available agent is only milrinone. Then coming to the other agent, vasopressin. This is an endogenous agent which is secreted by hypothalamus and stored in the posterior pituitary. It is a potent vasoconstrictor. It is also called antidiuretic hormone. Normally, in the physiologically, it is secreted whenever there is increase in plasma osmolality, whenever there is hypotension, hypoxia, pain, nausea. All these trigger secretion of vasopressin endogenously. But then the action of vasopressin would be, there are two receptors, V1 receptors and V2 receptors, which are important for us. V1 receptor is present on the vascular smooth muscle. Stimulation of this V1 receptors leads to vasoconstriction. And V2 receptors are present on the renal collecting tubule. They act as, they help in antidiuresis, that is water reabsorption. So, and it is, vasopressin is used whenever you don't find a response to norepinephrine, or whenever the norepinephrine dose is going very high. You want to curtail the dose of norepinephrine. Vasopressin is very useful. Vasopressin significantly has effect on the splanchnic and renal systems. So whereas norepinephrine has got effect on all the peripheral vasculature. So whenever norepinephrine dose is going more than 1 microgram per kg per hour, it is always better to start vasopressin to spare the effects, the tachycardic effect, the beta-1 effect of, and cardiotoxicity of norepinephrine. To curtail that, vasopressin is started. Vasopressin is usually started at a dose of 0.04 units per minute, or it can be started at 0.01 to 0.1 units per kg per hour. The other agent which has shown some promising results was calcium levosimendan. It is a calcium sensitizing agent. It goes and sits on the troponin C, and it sensitizes the troponin C and actin myosin complex to the calcium which is available. So this leads to positive inotropy. This levosimendan has also got action on the ATP dependent potassium channels. It causes opening of ATP dependent potassium channels in the vasculature. So this leads to vasodilatation. So this again, levosimendan again is a inodilator. So it causes inotropy and vasodilatation as well. So whenever you are using this agent, it is not very freely available. It was available. I think it is available. We have used it once or twice. whenever you are using this, it is better to start at a small dose of norepinephrine also to maintain vasoconstriction. Initially, it has shown a lot of promise, but later studies which have come have shown no great advantage over dobutamine. So the usage of levosimendan has not gone up pretty much as it was expected. Other agents which are used are methylene blue. Methylene blue is used in distributive shock, especially the septic shock, where nitric oxide CGMP pathway is in septic shock. Nitric oxide CGMP pathway has got a significant role, which leads to the shock. So this pathway is inhibited to certain extent by methylene blue. So methylene blue is also used as an infusion to counter the nitric oxide CGMP pathway and increase the vasoconstriction. But again, this is only in experimental stages now. Only a few small studies have shown some promising results, but it is not commonly used. Glucagon is also a good inotropic and chronotropic agent. It is used in specific indications like where there is beta blocker toxicity. People who have consumed lots of beta blocker tablets and come with toxicity, glucagon is a useful agent if epinephrine does not help. So problem with glucagon is high blood sugars, which are side effect of glucagon usage. So to use this all these agents, we have to ascertain the type of shock. So once if we don't know what kind of shock it is, and if we use whatever agent is available with us, it can lead to catastrophe. So first we have to ascertain what kind of shock it is. We have to decide what it is, then only start the treatment. So there are broadly 4 types of shocks. That is hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. Cardiogenic shock, as I said, it is usually the ventricular failure. Whenever there is ventricular failure, there is arterial hypotension and tachycardia usually. These are usually the signs. Whenever, if you come across a patient in your ER, any patient with altered mental function, any patient with mottled and clammy cold skin, any patient with oliguria, you suspect shock, some kind of shock. And if you do an ABG, you will always see elevated blood lactate levels in a shock. So in cardiogenic shock, there is usually low cardiac output, and SVO2, that is mixed venous oxygen saturation, is also low, but central venous pressure is high. So echocardiography is diagnostic, and this can be due to the most common cause is myocardial infarction. Other causes can be a decompensating cardiomyopathy or severe valvular disease. All this can lead to cardiogenic shock. So usually the cardiogenic shock, the treatment would be, if it is say myocardial infarction, the treatment would be revascularization as early as possible in whatever way, in either cath lab or CABG, whatever. But then if there is time and if the patient is unstable, you can start. Dobutamine is the preferred agent. Dobutamine is used, and if there is still hypotension persisting, it is always good to add some amount of norepinephrine to maintain the systemic vascular resistance as well. Hypovolemic shock occurs usually due to here the cardiac output is low and SpO2 is low, and the central venous pressure is CVP is low. So on echocardiography, you find small chambers with normal function. It can usually be due to hemorrhage or any fluid loss due to organ dysfunctions. This is usually managed by fluid resuscitation initially. After adequate fluid resuscitation only, start some kind of vasopressor. Norepinephrine would be preferable to avoid any volume overload. So, but adequately volume has to be replaced. Then only start norepinephrine. Otherwise, it can be detrimental. Then distributive shock. Distributive shock can be due to sepsis. It can be due to anaphylaxis, or it can be due to our spinal anesthesia. Any neuro shock can be. Neurological shock is usually distributive shock. Any spinal cord transection or our spinal anesthesia itself can lead to is a kind of distributive shock. That is, there is severe vasodilatation. Here, the cardiac output is normal or high because there is decreased afterload. The cardiac output is usually high. Then the preferred agent would be norepinephrine, or in case of if you are requiring larger doses of norepinephrine, you can add vasopressin and epinephrine also. Obstructive shock is usually due to pericardial tamponade or pulmonary embolism, which are usually they require or are a tension pneumothorax, which usually require treatment of the cause, rather than none of these agents are going to help in a obstructive shock. So I would like to discuss a couple of case scenarios. A 56-year-old female comes with community-acquired right upper lobe pneumonia. She has heart rate of 140, BP of 75/30, and a temperature of 38.7. Her peripheries feel warm. So in this case, the patient has tachycardia, there is hypotension, there is temperature, and there is a diagnosis of pneumonia infection, and the peripheries are warm and bounding. That means this is a kind of distributive shock, or to be specific, it is a septic shock. So the initial management would be fluid resuscitation with about 30 ml per kg of fluids. Then antibiotics and cultures have to be sent. Here, the preferred agent is norepinephrine and vasopressin. In this case, if you are going to start dobutamine or a low dose adrenaline, it is going to further deteriorate the condition. So it is always better to start with a norepinephrine. Even in the latest surviving sepsis guidelines, norepinephrine is a preferred agent, followed by vasopressin and adrenaline. So, but then at later stages, if there is any cardiomyopathy, septic-related cardiomyopathy leading to pump failure also, then probably you can add some dobutamine. The second case scenario is a 70-year-old man with acute anterior myocardial infarction is received immediate conservative treatment, but is having tachycardia, hypotension, peripheries are cold. So this is and he's oliguria. So this picture typically resembles that of a cardiogenic shock. Here the as I said, revascularization. Now it is not preferred to start any sympathomimetic. It is better to avoid any sympathomimetic, because starting any sympathomimetic without hypotension, it would be detrimental to the. It can cause cardiac toxicity. So revascularization is the initial treatment of choice. If it is not available ASAP, then start dobutamine or milrinone, and then levosimendan. Patient 25 male admitted to surgical ICU with blunt injury abdomen, multiple rib fractures. His heart rate is 140, BP is 100/70, cold peripheries. This is a typical hypovolemic shock due to hemorrhage. Here, the treatment of choice. All the injuries are closed injuries. So there is most of the times there is no ongoing bleed. Whichever has happened during the accident. So in these cases, it is better to start fluid and blood resuscitation. Then after you have done some good amount of resuscitation, then only start. If hypotension is persisting, then start norepinephrine or vasopressin. Then patient has to be worked up and surgically dealt with. So to summarize all these agents, it is this one table is very important. If you see this table, you understand on what receptors they have action and when to start them. So dopamine, if you see, it is got prominent action on beta 1, DA1, and alpha 1 and beta 2 also. So it can be used in any. It is an agent of choice and can be used in shock. But nowadays, it is not the agent of choice, as I said, because of the significant tachycardia which it causes. And even in renal dose also is not preferred nowadays. It has not shown to improve any renal outcomes. No renal outcomes. There is no improvement in the renal outcomes. So dopamine, renal dose of dopamine, the concept is outdated. Then dobutamine is significantly beta 1 agonist. So they used as whenever there is pump failure. Norepinephrine, significant action on alpha 1. So good agent as a vasoconstrictor. And it has got beta 1 also, but to a lesser extent when compared to alpha 1. So it can, at higher doses, it can lead to tachycardia and arrhythmias. Epinephrine has got high alpha 1, beta 1, and beta 2 actions. So it is more prone to cause arrhythmias when compared to other agents. Isoprene, if you see, it has got action only on beta 1 and beta 2. There is no alpha action. And similarly, phenylephrine has got only alpha action, no beta 1 and beta 2. Milrinone, amrinone are all, milrinone is phosphodiesterase 3 inhibitor. It is usually started at a dose of 50 micrograms per kg bolus given over half an hour. Then we give an infusion of 0.375 to 0.75 micrograms per kg per minute as an infusion. Amrinone, as I said, we don't use nowadays because it is shown to cause thrombocytopenia. Then vasopressin acts on V1 receptors and V2 receptors. It is at higher doses. This also leads to coronary vasoconstriction and arrhythmias. So higher doses are usually avoided. Common fixed dose is 0.04 units per minute or 0.01 to 0.1 units per minute. A bolus of 40 units IV bolus is usually given in resistant CPR because in CPR it has shown to decrease the endogenous vasopressin levels. So vasopressin, if given, has shown to have some benefit. Then levosimendan is usually given as a loading dose of 12 to 24 micrograms per kg over 10 minutes. And then 0.05 to 0.2 microgram per kg per minute is given as an infusion. The problem with levosimendan is it has got very long half-life. Even though after IV dose, even though the half-life is said to be about 4 hours, but then the action of levosimendan can go up to days. So you have to be careful with that whenever you are. So thank you very much for your patience.
Thank you very much, Dr. Prashant. That was a very vivid presentation, and the case discussions were really nice. And thank you for taking this in such a short time and presenting it wonderfully. So now here we have one question from Dr. Sri Pooja, who is asking which inotrope should be used in a patient with AKI in hypotension.
Pardon?
Which inotrope should be used in a patient with AKI in hypotension?
We can use dobutamine.
Okay. Any more questions?
I request Dr. Satyanarayana sir for his inputs and anything to add.
Good evening, everyone. Dr. Prashant.
Good afternoon, sir.
Yeah, good topic. It's really because most of the PGs and all, we have enormous drugs are available. Exactly which clinical condition to start with and what to start with. You have emphasized very briefly. precisely. Only thing is, how long, what is the rationale? With septicemic shock, is it not add to noradrenaline, vasopressin and all? How long you take? Is it the escalation of adrenaline dose? It prompts you to add vasopressin, or anything, or what exactly the clinical response? According to the response, you add vasopressin to that. What is it?
Yeah, usually it is the escalation of noradrenaline dose, sir. So whenever we are going more than 1 mic per kg per minute, and there is the response is not much. After the despite your fluid resuscitation, first thing is the fluid resuscitation. They have emphasized to give about 30 ml per kg fluids before starting norepinephrine. Because if you are going to start norepinephrine with empty vessels, then it can be catastrophic to the organs, end organs. So first fluid resuscitation, then norepinephrine, then you start. If it is going, the dose is going higher. If it is going more than 1 microgram per kg per minute or 2 microgram per, you can go up to 3 microgram per kg per minute. But once it is going to more than 1 microgram per kg per minute and there is not significant response, it is always better to start vasopressin, because whenever because the action is totally different. These are different receptors which it is acting on. So it is always better to add a different agent rather than when you have already started norepinephrine, you are going to add epinephrine to that, adrenaline to that. They are almost the same receptors which they are going to act. So it does not help much. Whereas vasopressin is a totally different set of receptors. So it would be a better idea to start vasopressin rather than norepinephrine. Rather than epinephrine, whenever you want a second agent. And a de-escalation is as early as possible. Whenever you have achieved your goals, it is always better to de-escalate, because any of these drugs, if you are going to use them for longer times, they are going to cause problems. So it is better to de-escalate as early as possible.
Yeah, one more clinical scenario, Dr. Prashant. You have a cardiogenic shock secondary to MI, severe cardiogenic shock, but the facilities are not available. There's there's still time there to revascularization. But the patient is severe hypotension, acute LVF with a severe pulmonary edema. So here, exactly the choice of, again, the inotrope, and because the diuresis, because we are furosemide is going to be given, and another, so there is a problem with hypovolemia and precipitating further hypotension. How do you want to balance this hypotension induced with the diuretic and the choice escalating the dose of the inotrope before revascularization facilities are available?
If there is a cardiogenic shock with pulmonary edema and hypotension, it is better to use NIV rather than diuretics first. You can go with non-invasive ventilation. You can start BiPAP, and then you can start dobutamine. With good amount of dobutamine, if you are not able to achieve your mean arterial pressures, you can start some amount of norepinephrine also, about 0.04 mics per kg per minute. You can start of norepinephrine, so that vasoconstriction is also maintained. So that would be a better idea. Adrenaline is not a good agent of choice in this condition. Dobutamine would be better. If dobutamine is not working, then probably you can go for milrinone, because milrinone has shown to cause decrease in pulmonary artery pressures also. So you can go for that if it is available, but it is not very freely available in all the centers because we don't use it routinely. So once your pressures improve, probably then you can use diuretics. But then when pressures are low, it is better to start with NIV to counter the pulmonary edema rather than giving diuretics.
Okay. Good, Prashant. Ramakrishna, anyone, let them, anyone, seniors or?
Sir, now I request Deepra Singh sir to give his inputs.
Sir left.
Oh, Dr. Prashant, you have one more question. Is there a specific order in which inotropes are finally stopped if the patient shows improvement?
Specific order, I would say if I am inotropes or vasopressors.
Inotropes.
Inotropes, we usually, if we are using, say, dobutamine and epinephrine, then it would be better to stop epinephrine than come down on dobutamine, because epinephrine has got the chronotropic effect of epinephrine is much more than dobutamine. So chronotropy is it increases oxygen demand much more when compared to dobutamine. So always come down on epinephrine, then come down on dobutamine. Whenever you are using norepinephrine and vasopressin as vasoconstrictors, it is always better to come down on when the norepinephrine, you have to come down on both. Actually, what we do is we taper both of them alternately. Whenever there is, patient if is on norepinephrine and vasopressin, we taper about 0.5 of norepinephrine, say in this hour. Next hour, we taper 0.2 ml of vasopressin next hour, and then taper norepinephrine. So once norepinephrine has come to a moderate level, then we taper down vasopressin. But then if you are using both of them, it is, if you want to taper one of them, it would be better to taper vasopressin before tapering norepinephrine, because it decreases the splanchnic and liver blood flow pretty much, very much. So it can lead to ischemic hepatitis. So whenever you are using higher doses, and bowel ischemia is also more with vasopressin. So it is always better to come down on vasopressin initially. But then if both are in moderate levels, you can come down alternately and taper both of them.
I request Dr. Matthew sir. Dr. Matthew sir is here, and Dr. Shiva, Professor Anaesthesia, Nilofer Hospital is also here, among the senior persons. And also our beloved President, Dr. Veeresham sir is there. Any comments, sir?
Nice presentation.
Thank you, sir.
Nice presentation. Thank you.
Thank you, sir.
Yeah, it is a very good presentation. Nothing more to add. Excellently done. And
Thank you,
also good effort by the organizers, Veeresham and Ramakrishna Reddy.
And also Dr. Banalakshmi, and guided by Dr. Satyanarayana sir.
Yeah. All seniors, and of course, ever this thing, dependable Banu.
Thank you, sir. Sir, there is one more question. What is the role of phenylephrine?
Role of
Phenylephrine.
Yeah, phenylephrine, as I told you, it is usually used as bolus whenever in our anesthesia practice, intraoperatively, whenever there is hypotension due to induction agents or hypotension post spinal anesthesia. The other thing is whenever you require only alpha blockade, alpha agonism, alpha 1 agonism, like in conditions of HOCM, where there is, if you increase chronotropic action, if you stimulate beta receptors, it is going to deteriorate the condition further. So in such conditions, you don't want any chronotropism, any inotropism. So in such situations, you require only vasoconstriction. So phenylephrine is a good agent of choice in HOCM, or you can use, it is a good agent of choice in PET spells. In PET spells, the problem is the same. There is hypertrophy of outlet. So if you increase inotropy, the muscles are going to close the outlet. So you don't require any inotropy. In such conditions, phenylephrine is the agent of choice. Even in severe AS, where there is a fixed output and you want to maintain the mean arterial pressure, you don't want any increases in heart rate, any increases basically only in the heart rate rather than contractility. So you don't want any increase in heart rate, but you want to maintain mean arterial pressure. In such situation, phenylephrine is the agent of choice. And apart from that, in our routine cesarean sections in parturients, phenylephrine is found to be a better agent compared to ephedrine and mefentermine. Mefentermine I have not mentioned. Mefentermine is again a sympathomimetic, synthetic sympathomimetic agent, indirectly acting. So most of its actions are indirect. That is, it stimulates release of norepinephrine, whereas ephedrine at least has some direct and indirect actions. So mefentermine is phasing out nowadays. nowadays, only available in few centers.
Sir, we have one more question. Can we use dopamine as an inotrope in patient with hypotension with AKI? Now that the role is controversial, what does your experience say?
AKI and hypotension. Do you mean renal dose of dopamine or?
Yeah, renal.
As a renal dose of dopamine is now outdated. We don't use. I have personally used it. It has shown to increase urine output, but then many studies have come which have said that it does not show any renal protective effect. So there is so much of evidence. I don't think it is a good idea to use renal dose dopamine.
The one question, very lucid and comprehensive presentation. How do you deal when a person requires dopamine and dopamine for more than 48 hours? They say there is tachyphylaxis after 48 hours with dopamine and dopamine. So
yeah,
how do
whenever you are, yes, tachyphylaxis is there with all these agents. So if you have used dobutamine, probably you can switch over to milrinone or epinephrine. Milrinone is not available. Epinephrine also can be used. Epinephrine at moderate doses or lower than moderate doses acts as a inodilator. It acts similar to dobutamine. Probably you can use dobutamine and norepinephrine instead of dobutamine and dopamine.
Sir, I have one more question. You said in hypovolemic shock, after fluid resuscitation, we can start norepinephrine if the patient is not responding. But then patient already in AKI because of the hypotension. Do you suggest norepinephrine is ideal compared to the other drugs? Because norepinephrine itself causes decreased renal perfusion.
Yeah, but then but you have to, for AKI to improve, you have to first improve the pressures. Yes. If the main arterial pressure is less than 65, it is not going to help the patient. So if you have adequately resuscitated the patient, you always you can use norepinephrine to increase the main arterial pressures.
Okay. Thank you, sir.
So if there are no questions, I think you can conclude, Dr. Banu.
Yes, sir. Once again, I thank the team members for their cooperation in bringing up this event, and I thank Dr. Prashant for taking this topic in such a short notice. Thank you so much, sir. And thank you all once again for giving me this opportunity to moderate this session. Over to you, Ramakrishna.
Thank you.
Thank you, sir.